Hi, this is Dr. Bhargava. Here is the next video in the series, Body Imaging Case Review. This is our first patient and they underwent an MRI of the pelvis. I'm showing you small field of view, sagittal and axial image, and here the interesting finding is the appearance of the uterus. It seemed to be pulled forwards and it seems to be attached to the abdominal wall, also seen here and here. This is something which is commonly seen post C-section, and this is one of the complications of C-section, where after they undergo a C-section, the uterus gets adherent or attached to the anterior abdominal wall, and on imaging it seems like it's been pulled forwards and rotated like we see here. Usually it's just an incidental finding and I'm not aware of any symptoms that this can cause. This is our next patient. They underwent a left-sided nephrectomy. That was a laparoscopic procedure, and we see the signs of it right here with absent kidney on the left side, and they presented with severe abdominal pain 1 or 2 days after their surgery. And so on their CT scan, we find that they have small pleural effusions, left worse than right. They have extensive chest wall emphysematus change, also seen right here. And so this was unexpected after their laparoscopic surgery, but this can be seen as a complication of a prior laparoscopic surgery where chest wall or abdominal wall emphysema gets worse after the surgery. Here is our next patient. We have performed a multiphasic CT to look at or evaluate a tumor in the liver, non-con, arterial phase, portal venous, and delayed. We see this hypodensity which fills up partially peripherally, and so the characteristic appearance is discontinuous peripheral nodular enhancement, and there is centripetal filling, so from outside to inside it will fill up. And on the more delayed image we find that it is isodense or slightly hyperdense to the surrounding liver, and on this delayed image, which is generally acquired at 3 to 5 minutes, most of it has filled with contrast. And so these findings are characteristic of a hemangioma. Sometimes it may take up to an hour for the entire tumor to fill up with contrast. Here is our next patient. They presented with necrotizing pancreatitis, and we can see that the pancreatic parenchyma is missing and replaced with this very large collection. And they've had a procedure where a pancreatic duct stent has been placed, but this has moved further into the third portion of the duodenum. And so the stent has migrated proximally into the duodenum. This is our next patient. There are 2 images in the lung windows showing the chest in the axial and the coronal projections. There are ground glass opacities in a perihilar distribution seen on this axial image and also on the coronal image. They've had prior sternotomy. And so these findings suggest pulmonary edema, or the most common cause of this finding would be pulmonary edema, and that's what this patient had. When the pulmonary edema gets worse, these patients would develop bilateral pleural effusions. This is our next patient, and here we have performed a MRI of the pelvis to evaluate hypodensities or cystic foci that were previously seen on their CT of the abdomen and pelvis behind the rectum and close to the coccyx. And so as we look at the small field of view T2 weighted images, we find these T2 hyperintense densities that are abutting the posterior aspect of the rectum, and also the musculature and fascia that is anterior to the coccyx. DWI and ADC showing no restricted diffusion, and these findings are characteristic of tail gut cysts. And so if symptomatic, these are frequently removed surgically. They typically do not show any enhancement. Here is our next patient. They presented with urothelial cancer, and on the left we have two images from their CT scan showing that there is a stent on the right side, and in the lower ureter and involving the urinary bladder there is a large ill-defined tumor, and that's one of their urothelial tumors. On their whole body FDG PET, that tumor is FDG avid, and also there is another tumor involving the mid-ureter, which is also seen right here. And so we know that TCCs can be multifocal, and so we have to pay attention to the entire tract to make sure that we are not missing any tumors. This is our next patient. They were evaluated with imaging after an episode of acute pancreatitis. We are looking at MRI images of the abdomen post-contrast, non-con arterial, portal venous, and delayed images on the top, followed by T2 weighted images, axial fat sat and coronal non-fat sat, and then DWI and ADC images. There is no restricted diffusion, there is no enhancement, and on the T2 weighted images we find that there is a complex cystic structure right there with some internal debris, and so this patient was diagnosed with walled-off necrosis. Here is our next patient. They were evaluated with a CT of the abdomen and pelvis with contrast, and the axial view shows that the kidneys are enlarged bilaterally and the enhancing parenchyma is very small, and the kidney is predominantly replaced with these cysts bilaterally. Here we find the same finding, that the kidneys are enlarged and replaced by cysts, and this pattern is suggestive of autosomal dominant polycystic kidney disease. These cysts can rupture, leading to symptoms of abdominal pain. They can also undergo hemorrhage that can also cause pain. They can develop infection or acute pyelonephritis, and also these patients are predisposed to developing renal cell carcinoma. When you encounter such a study, make sure you measure the dimensions of the kidney and report the volumes of both kidneys separately. That's important in their management and treatment. This is our next patient. They were evaluated with CT of the abdomen and pelvis. We find that on these images that there are some post-surgical changes and sutures, and adjacent to the sutures we find this thick-walled collection showing some rim enhancement. And so when there is dehiscence of the sutures and some material leaks out into the intraperitoneal compartment, then it can develop into an abscess, and that's exactly how it would look like. So a post-surgical abscess from sutural dehiscence. Here is our next patient, and these are serial CT scans showing a cyst arising from the superior pole of the left kidney. This is a non-contrast enhanced scan showing the cyst, and there is a follow-up scan showing that it is smaller, and on a further follow-up scan it is even more smaller. And so renal cysts can rupture. When they rupture, they can be symptomatic, causing abdominal pain, and on imaging there is some surrounding fat stranding and the cyst becomes smaller. So a temporal evolution of a post-traumatic cyst rupture. This is our next patient, and this is interesting because they had two different kinds of liver tumors that we were able to diagnose or confirm on their MRI of the abdomen performed with and without contrast. And so contrast enhanced images are on the top, and then we have the T2 weighted image at the bottom, and then we have DWI and ADC images showing that none of these tumors have restricted diffusion. So one of these tumors is seen right here. It has a central scar, which is shown right there, and the other one is much more T2 hyperintense and sort of well defined and uniform. So let's start with that tumor. So that tumor shows no enhancement on the arterial phase, and then as we go from portal venous to delayed phase, it shows enhancement suggestive of a hemangioma. And the other tumor shows arterial phase enhancement right there, and then on the much delayed phase, these are 20-minute delayed images, the contrast was EOVist. We find that there is contrast enhancement on the 20-minute delayed phase along with a hypoenhancing central scar. And so this other tumor is a FNH. And so sometimes two tumors or more than two tumors can exist side by side, and MRI is the best modality to evaluate and confirm these different tumors. Here is our next patient. They presented with fever and chills and respiratory symptoms, and they were suspected of having septic embolism. So a CT scan of the chest was performed with IV contrast, and we have two images, axial image shown in the lung windows and soft tissue windows, and at the same level, and then we have the coronal image in the lung window at two different levels. And so let's start here on the axial image. There are multiple bilateral peripheral nodular densities with cavitation. And there are effusions on both sides, right, worse than left. And then we see the same finding here on the coronal images. There are wedge-shaped peripheral densities, and some of them are cavitary. And so these findings are classic for septic embolism, where there are wedge-shaped pleural-based densities which become nodular and develop cavitation. And also these patients will have reactive pleural effusions. This is our next patient. They were diagnosed with tuberous sclerosis, and we have some findings seen on their CT scan of the head, in the brain, some findings, hematomas seen in the bone on their CT scan of the abdomen and pelvis in the bone windows. And then in the kidneys, we are trying to evaluate tumors which are seen on the non-contrast enhanced scan bilaterally, and post-contrast, these tumors show contrast enhancement. And so these patients have renal angiomyolipomas, and they are very common in tuberous sclerosis patients. They are often multiple and bilateral. And it's not very clear in this patient, but they generally have fat in them, and they generally show contrast enhancement. Here is our next patient. We performed a CT of the abdomen to evaluate their left kidney, and so it was a multiphasic CT starting with non-con arterial phase, portal venous, and delayed, and then a coronal image showing that they have a large stone that is obstructing within their left ureter. And we find on the non-contrast enhanced image that they have a percutaneous nephrostomy catheter, but as we go through the contrast enhanced images, we find that there is hypoenhancement of the left kidney compared to the right, suggesting that they are still obstructed. And then we see this dilated collecting system suggesting hydronephrosis. And so that means that this percutaneous nephrostomy catheter is not working, and it should be reevaluated and probably exchanged. Here is our next patient, and the finding was incidental, where they underwent a CT scan of the chest, and on that CT scan, in the lung windows shown here on the axial and the coronal image, there are multiple nodules seen bilaterally of different sizes in random distribution. And so this finding suggests that they have metastatic disease. Here is our next patient, and we're looking at their single frontal view of the chest. Cardiac silhouette is enlarged. There is mild perihilar vascular congestion, suggesting congestive cardiac failure. They may also have a small effusion on the left side as the costophrenic angle is blunted. This is our next patient, two different frontal views of the chest. The image on the left is showing a large left-sided pneumothorax. Here in this part of the chest, there are no lung markings, and this is the border of the collapsed lung. And after placement of a chest tube, we find that the left lung has expanded and the pneumothorax has completely resolved. Here is our next patient, and the finding was very subtle. Generally, we scroll through the axial images to look for findings and correlate with coronal and sagittal images as needed. And so our attention went to this linear hyperdensity in their gluteal fold, and this is how it was seen on the coronal image. And on the sagittal image, it was clear that there is a blade that they are trying to hide in their gluteal fold, and this was a study or a scan on an inmate, and inmates frequently try to hide sharp things in their body parts to try to escape or make some weapons out of these razor blades. And so for these patients, we have to be very careful in evaluating any hyperdensities and evaluate the images in all different planes. Here is our next patient, and again, the abnormality was not very obvious on the axial images, which we typically read off. And so here, that inferiorly in the pelvis, we should never see the vagina or abnormal soft tissue density. And again, on the coronal images also, it's not very clear, but on the sagittal image, we find that there is a prolapse right there, vaginal prolapse. The uterus has descended also. And here's the urinary bladder and the rectum, which look normal. Thank you for watching.